All right, we are here today with a friend of mine, a great, innovative, practical surgical mind who has a particular depth of knowledge in podopediatrics, or the study of foot and ankle and leg pathology in juveniles and the pediatric population. He has a surgical discipline that's included president of the American College of Podopediatrics. Pat Agnew is with us tonight, Dr. Pat Agnew, and he trained under one of the legends of, or I guess one could say the father, at least in the podiatry world of podopediatrics, wrote a text about children's foot deformities and altering them at an early age. And Pat, once he completed his residency, got a lot of trauma experience and other unique experiences in the Naval Reserves. So what I'm going to start with after that introduction, Pat, is just you giving a brief sort of, and I just kind of thought of this on the spot, of a synopsis of maybe some of the most interesting learning cases that you had that still affect what you do today, you know, in the trenches of your clinic, either from Dr. James Gailey or from some of the experiences that you had on your rotations in your residency, because that might be interesting. And then later we'll share some things that I think have added to my clinical set when we've had conversations, which has been a nice thing to have that interaction. But I'll let you get started with kind of some of the things that you felt were impactful and have given you perspective, and some specific knowledge bits you've got with foot and ankle.
Thank you for the introduction. Yeah, really pleased to be with you tonight. I think this is so cool that you're using the, this kind of crisis opportunity. You know, they talked about the Chinese pictogram being the same for each, of being at home, but making the most of it by sharing valuable information, I think, with our colleagues and our patients through this format. So bravo, good job, man. I think that's a really interesting way to talk, is about the experiences in the past. I did have some very lifelong lasting experiences with Dr. Gailey. In fact, I'm sooner or later going to write a book of what I call Gaileyisms, these different things that he would say from time to time that would really resonate later in my life, and say, yeah, I had no idea how right he was at that time.
Yeah.
One thing he always talked about was one of his other residents, Dr. Fran Lynch, was absolutely brilliant, just crushed his surgery boards, was top of his class at Temple, big physical guy, weightlifter, all that stuff. And so, of course, his very first case with Dr. Gailey as a resident was a pantalar arthrodesis. It's like started out, hit the ground running. But what they noticed was they did excellent bone correction on this particular patient, but it was a patient with neurologic disease. And over time, the foot reverted to deformity over a fairly short time. And what Dr. Gailey pointed out about that was that bones are not static, they're dynamic, they can be changed. Wolff's law, Delpec's law, they can be influenced by outside forces and mutate. And those outside forces, more often than not, are tendons. So Dr. Gailey often emphasized the critical nature of muscle strength, neurologic function, soft tissues, and their influence on the foot. This is right about at the same time where podiatrists were getting more and more into bone surgery and osteosynthesis, using screws and things, where prior to that it was maybe pins and plaster, if anything. You know, the old Austin bunionectomy didn't have any fixation. It was just a dovetail cut you shove together. And maybe not a bad thing. Sometimes the addition of a screw can allow some early range of motion, but you know, it was a really cleverly designed osteotomy to start with. So I guess the influence of soft tissues on outcomes, I think, is very critical when you're talking about foot and ankle surgery. Bones look like rocks, but they act like trees. So I always point out to my patients here, you go up on the North Shore of Virginia Beach and look at those trees that are battered by wind all day, every day, and they all lean and bend away from the wind. Bones do that too. If you have muscles pulling out of balance, if you have collagen and ligaments that are incompetent, you're going to get deformities that really good bone surgery won't solve. You have to also balance the soft tissues. So that's a Gaileyism that really stuck with me, and it's become particularly interesting to me later in my career. Not much later, a couple of years after I got started, I started getting into treating patients with connective tissue diseases. Just kind of stumbled into that. And we had this, the second annual meeting of the Ehlers-Danlos National Foundation was held here in Chesapeake, Virginia. That foundation has been kind of replaced by the Ehlers-Danlos Society now, and I have been all along a member of their scientific advisors panel since it was started. And that wasn't because I was any special knowledge or experience in Ehlers-Danlos Center. It just was because no one else was doing it. At this annual meeting, there were about 12 people present from around the world, really. And a hand surgeon, Pat Alosino, was running the meeting. I sat in the back, and he came up halfway through. He said, "Pat, are you interested in this?" I said, "Well, yeah, I figure their feet hurt. You know, I heard about it in school. I don't really know that much about it." He said, "Yeah, they're all complaining of foot problems, and nobody's really doing anything about it." He said, so like the next day, I guess I was the world's leading authority. And I kept going to annual meetings and collecting data and publishing where I could. You know, they're not a homogeneous cohort, so it's hard to write a paper, but you can certainly write pamphlets and book chapters and things, which I have, on connective tissue disorders. And I think they're a good prototypical example of just how critical soft tissues are. If every cell in your body is connected to the next cell by connective tissue, then you can have dysfunction in any organ system, musculoskeletal, immune, reproductive. They're all affected by connective tissue disease. And I do what I can to try to help with the foot and ankle problems.
I do have a couple follow-ups with that, and I'm glad you mentioned your involvement with the Ehlers-Danlos Society. I know there's a lot of different subtypes. What's a good general way that you can explain both to potential patients that'll be listening to this later and colleagues about the main subtypes of Ehlers-Danlos and about sort of the curve of people that may not be in the Ehlers-Danlos category but are leaning towards more hypermobility, and then how do you distinguish the two? Because I know that it's not always clear cut with a marker per se. Maybe you can.
Wow, that was very cogent. You went precisely to the core of a lot of controversy and communication in this. There have been a couple of nosology conferences over these past 30 years I've been involved with this, where they've tried to refine the terminology, redefine some things. The Human Genome Project, identifying specific diseases that don't really belong under the umbrella, and then this great vast spectrum of connective tissue disorders that really don't have another umbrella to go under, wind up being under the Ehlers-Danlos Society's purview. So right now, there may be 13 types and a couple of dozen subtypes, far beyond any useful information to a foot and ankle surgeon. I will say that some of the critical subtypes to be aware of are things like the vascular type, in which hollow organs can be vulnerable to rupture and sudden death can occur at a young age. That certainly stands out as one of the ones to properly diagnose and be aware of as you're trying to help with the foot and ankle issues. But also, I would say that most of what we do about the foot and ankle problems is applicable to all of the subtypes, and then also to those that may or may not be Ehlers-Danlos syndrome at all. What's sometimes or currently called hypermobility spectrum disorder. And we talk about the hypermobility type, and whether that's an actual type or whether that's just a shared phenotype that may not have any shared genotype. So yeah, accurate diagnosis of the right type beyond my capabilities. You know, when they talk about how complex the disease is and how it affects every organ system, there's a former head of our medical and scientific advisors panel who has Ehlers-Danlos syndrome, lives in South Bend, Indiana. She's a primary care physician. And she said, so because connective tissue can affect every cell in your body, in order to help people with hypermobility or with collagen diseases, you have to know everything about everything. I said, Heidi, I can't do that. You know, I'm a carpenter, you know, on a good day, a cabinet maker. So I might be able to make their ankle stop dislocating, but that's about it all. And she said, yeah, but they like you. You know, they don't like the research scientists that much. They like people who can make them feel better. But it is important to recognize that everything we do, even just to the foot and ankle, can have effects on the rest of the body. So for example, I had one patient with Ehlers-Danlos syndrome that I did a bunion operation on. And we've done modifications of that, which we've published a bit on posters and lectures so far, where we replaced the medial collateral ligament of the first toe with bone anchors that were designed for shoulder surgery or hip surgery, but we're holding that big toe straight. We did some bench work to find out how strong those anchors had to be by pulling apart cadavers and clinical experience. And we're trying to figure out the very best anchors for that purpose and best suture and try and get it all together. But it's coming along. For about 7 years, we've been doing variations on that procedure with generally very good outcomes. But we did this operation on this person. They went back to college. 6 months later, we're talking on the phone and patient says, you know, I'm still constipated. I'm like, well, stop taking your pain pills. And the patient said, no, I haven't taken those since, 3 days after surgery. And I said, wow, okay, that's interesting. So the patient went to a physical therapist who had some familiarity with connective tissue disorders. And that therapist found a pelvic tilt, probably caused by limping while the patient was getting over foot surgery. And it affected bowel movement. And with some therapy and some adjustment, get that pelvic floor back in the right place, bowel movements worked again. So, you do foot surgery and cause constipation for 6 months. That's how tricky it could be.
Well, I know that also in the area of soft tissue, and something that because you have a sports medicine bent as well, one of the people that I followed when he was more active was Ben Onig, and he's talked about the eccentric muscle movements and the effect on the soft tissue pocket, those vibrations that cause a lot of the chronic lower extremity tissue damage. And one of the reasons I got interested in that, and some of the stuff that I've been doing with a company that I work with called Ing Source, is these sleeves or compression braces. And what I think that they do, my thought on that is that they help mute some of those soft tissue vibrations.
So free commercial. Yeah.
Okay. There you go. Pat was one of the people, along with a couple of, Howard actually, who's here tonight, was one of the early testers and users of the splint that I came up with for turf toe and hallux limitus. But I know that you've been coming around a little slower to the idea of how much just a compression sleeve may help, but I hope you do give it a try in some of your Sievers patients, and just to see. And what's interesting to me, and it may sort of be a kinesthetic effect, just a sensation effect, is that, like you knock your head and you rub your head, and then it feels a little bit better. But there may be something to, being swaddled, and you might be able to speak to this with some of your pediatric experiences, why that body part might feel better, might take the edge off almost immediately. And not everybody has the same effect too. And I think a lot of it has to do with people's neural input, how swollen the tissue is, whether you can have any pressure, because we all know that if something is too swollen and there's too many inflammatory cells in the area, whatever you do to touch it is not going to be acceptable unless you throw them in a cast that's got a lot of padding. I don't know if you, let me try to kind of hone this into a question. What have been, and I'll frame it with some of the chronic growth anomalies that we see, Sievers, Osgood-Schlatters, and maybe you can first sort of set the framework with the main ones that you treat, but then also how you believe that not only kind of keeping the bones fixed and the alignment fixed, but just addressing the soft tissue as at those insertions and origins of that tissue, how that might influence the result. So I guess the first part of the question is, tell us a little bit about the most common things that you see day to day in your clinic with juvenile growth pains and anomalies. And then the second part of it is some of the common ways that you treat those, both with more rigid structures and surgery, and then some of the ways that you think that the soft tissue can be handled.
Interesting. So I want to applaud your efforts in developing the device. I think it's brilliant, and I am a true believer. I have not dispensed nearly enough, and I blame myself because of my focus on so many surgeries. We have surgeries stacked up till March. I've had the busiest year of my career, and I was busy before this year. I blame COVID. I think, when you have a day off work, you go get your oil changed and you maybe go to the dentist, and, I think everybody had a year off and they all want their foot fixed now. So I've done emergency surgery every weeknight since May. And that's just nuts. In addition to my usual 2 block time surgeries per week, and, typically a dozen surgeries a week now, it's crazy. And so I'm just taking care of surgical patients perioperatively, and really just haven't been good about managing things like post-operative splinting and such. And I really need to get a greater emphasis on that.
Well, I just want to interject. I think it's hard to introduce a lot of new paradigms to our practice unless you have more dead time where you can think and reflect when you're as busy as the type of practice that you've developed, where you're a referral source in the Tidewater area to a lot of the basic ankle trauma and emergency infection surgery that you do. So I think that we only have a certain amount of bandwidth, and maybe if nothing else, by taking the time at night, and this is one of the things that I'm hoping to get gained by this, is both learn from my colleagues and hopefully share some ideas with them that they can think about afterwards. But I think, and Howard and I have talked about this too, sometimes it's just tweaking things just a little bit as to how to make something more accessible. Does it mean having that stuff at the ready that your assistant can just, bring it up, or even having stuff that is stacked in front for patients to be able to review and see and pick up and ask questions about. I'm another thing I want to share real briefly is that we first came into contact. I can't remember if I met you through the Virginia Beach meetings, and I think that was the first contact, but I had heard about you and was interested in children's foot deformities, and then you had invited me when I was taking a look at one of your colleagues that was selling his practice to stay at your house. And then I also had a chance to, I think, spend a little bit of time in your clinic that same weekend, or at least we talked over some pizza or something about some of the stuff that you were doing with kids' foot deformities. I wish I had more of that in my practice, and something I'm still trying to develop, and I guess it's never too late, but I am interested to kind of hear the most common things that you address, and maybe some little things that you've learned along the way of, with your experiences for, 30, 40 years, 30, 35 years at least of doing it. So I'll let you kind of take the floor.
Yeah, so excellent point. I think just about every good idea I've ever had professionally has been while riding on a plane to or from a meeting. I'm making notes, my head's clear, had a good meal, and I'm not doing the day-to-day hustle of just trying to get sick people well. As far as most common entities in children in our practice, I guess there's nothing common about our practice. We have people come from Norway with Ehlers-Danlos syndrome. We have kids from all around the region referred often by other podiatrists and other specialists. And so we see a very, very broad and sometimes bizarre variety of foot and ankle issues, and sometimes foot and ankle manifestations of systemic issues. But sure, Sievers is extremely common. Now, our experience has been that usually by the time they get to us, they've exhausted typical conservative recommendations or non-invasive recommendations. And so they've worn different shoes, they've iced, they've stayed out of sports. Oh, and by the way, I completely bow to your expertise in sports. You mentioned that I have some knowledge of sports. My knowledge of sports is being an athlete. I did 30 triathlons in the military, tried to stay physically fit, and all the units I was in were physically demanding units. They were field units. So my interest in sports is purely selfish. Any experience or knowledge I have is based on like people following me home from a race or fellow soldiers and sailors and Marines getting hurt in the field. So yeah, you're the expert. But I do consider, well, when we talk about growth problems, you never have growth pains in the upper extremity. That's Louis DeCaro's statement, and I think it's really accurate. They're always in the lower extremity. So they're not really from growth, they're from gravity and the changing effects of gravity on the changing body. So as children go through different stages, they suddenly put on a lot of weight, they suddenly put on a lot of height, and a pre-existing condition like hypermobile or overly pronated foot or very high arch foot all of a sudden has a lot more to do. And at that point, symptoms ensue. Now, happily, some of those symptoms are transient, might take care of themselves, but for these days, for a 10-year-old athlete to lose 2 years of competitive experience to something like Sievers can be devastating. You do a sport like surfing or skateboarding, which are the sports that I'm most involved with these days, or extreme sports and board sports, partly because I live in Virginia Beach, partly because my son was a highly competitive athlete as a little kid, and we traveled around the world for competitions. And partly because I still compete in those things at the old guy level. It's kind of like a bowling league. Everybody gets a trophy. We all show up. Probably more relaxation than competition. But if you lose 2 years of sports or 10 to 12 years old as a surfer, you're done. Your career is over pretty much. So it's important for us to find effective therapies. And I got to say, I don't have any magic tricks there. We use ice and rest and not much rest, usually active recovery, padding, heel lifts, bad cases, immobilization with a cam walker or something like that. But I am looking forward to trying some compression. I love the term swaddling. That's awesome. And based on pain gate theory, the idea that you can cause a counter irritant, you can, things like Bengay, you rub it on your shoulder, does absolutely nothing for your shoulder. It only irritates your skin enough so you don't notice your shoulder.
Right.
So if a swaddling of a foot that has pain in a deeper area like the apophysis or the epiphyseal plate can distract from pain there and allow a kid to get back to function quicker, I'm all for it, whether it has anything to do with healing it or not. And maybe it actually heals it too. I don't know. I don't know why some kids get Sievers and some don't, or Freiberg's or Islands or Asmans or any of those. There are all kinds of and there's this controversy about which are apophysitis and which are osteochondrosis or osteochondrosis dissecans, or all kinds of terms that kind of overlap and get confused there, but that's a whole lecture for a pediatric podiatry class.
Well, listen, I'm glad that you don't get too hung up on that, because I I felt bad because I was talking to Howard just before about the best way to address the question. As the follow-up, though, there are things that you do influence, and this I'm sure you picked up from Dr. Gailey about influence in foot early, and about sort of the old saw that a kid will outgrow a metaductus versus intoeing that's coming from, you know, another level. So maybe you could.
It's 62 years old now. It didn't go away yet. Still waiting.
So what refresh, and this could be for patients that are listening to this too. Give us sort of an overview of the closing time curve that we have to influence something as basic as metaductus, and then you could talk a little bit about calcaneal valgus if you wanted to. Clubfoot probably less common, but maybe give sort of a synopsis, and then some of the things that you do first line.
So to your first statement, yeah, I'm a lumper, not a splitter. I'm a clinician. I'm looking for Occam's razor. I'm looking for the simplest answers, most direct solutions, because that's what my patients want too. But always keeping an eye on what might be the worst case scenario. That's how I teach my residents. Look at the obvious thing, treat it, but recognize that when you hear hoofbeats, sometimes it's a zebra. In fact, that's the kind of mascot of the Ehlers-Danlos Society, is zebras, because sometimes it's not a horse. But also, I'll, like Dr. Gailey often did, I'll quote Hiram Kite that every day that a pediatric deformity is allowed to exist is a golden opportunity lost. You know, they used to joke about, like with a clubfoot, you almost want a limb presentation birth where the foot comes out first so you can start manipulating it before the shoulders are delivered. Every moment you're losing the influence of the maternal oxytocin. The cartilage that's turning into bone is getting stiffer and stiffer. So always, in all of these things, earlier is better. I'm absolutely convinced of that. I wish I had hard data to prove that. And there is contrary data out there, especially when it's misinterpreted. So my nemesis, but also one of my heroes, is Lynn Staley, a pediatric orthopedist from Seattle, retired some years ago, but he collected a huge amount of data on pediatric foot and ankle problems, metatarsus adductus, flat feet, intoeing, outtoeing. And he was kind of a nihilist. His interpretation of it was that most kids outgrow these things. Now, I had some face-to-face conversations with him. I would sneak into these foot and ankle orthopedic lectures wearing my Navy uniform. They thought I was just another Navy doctor. And I'd attend, and I'd go up to Dr. Staley and say, you know, I really appreciate you collecting all this data, but I think you've misinterpreted it. The fact that something is common doesn't mean it's normal. And if that were the case, neither of you guys would be wearing glasses. You know, certainly nearsightedness, farsightedness, very common things, but we treat them. We don't consider them normal. We consider pathological conditions that happily there's treatment for. Overbites, even a little more esoteric, scoliosis. You know, these things are common, but they're not necessarily normal, and there can be pathologies related. So early is better. When I was talking about most common presentations of problems, unfortunately, they don't always present at the optimal time. In fact, that's usually not the case. Like when people start to notice something like fatigue from a hypermobile kid with a pancake flat foot, he's like 8, 9, 10 years old. He's overweight. He's sedentary. He's, you know, you missed that window when he was 6, when an orthotic could have had a huge influence. Again, can I prove this? No. I mean, these kind of, to prove these points would take a 30-year-long Framingham heart study type study. And by the way, no mother is going to allow their kid to be in the control group. And so you have to take some things on faith and experience. when they tell you metatarsus adductus goes away, try operating on some bunions. And you'll see metatarsus adductus every day. When you think tibial torsion goes away, there was a great series in clinics and orthopedics, clinics and orthopedics and related research back in the late 80s, early 90s, where they were doing a series on knee surgery. And they talked about how often when they're doing knee surgery, they have to address torsional anomalies in the tibia or the femur in order to get a good outcome with knee surgery. Where does torsional anomalies come from? Did they just drop out of the sky? No, they were there from birth. And that's why, by the way, you're getting a knee surgery done at 50, because you were born to have that problem. Now, could it have been corrected as an infant? Maybe a pre-walker? Maybe. Dr. Gailey, Dr. Kite, others would say absolutely. Adding back to ancient Egypt when they used linen and egg whites to put casts on babies and straighten things out. I think they were onto something. And that is unfortunately not in vogue right now. There's this powerful group set up by Dr. Staley that actually goes around the world discouraging intervention in pediatric foot and ankle deformities. I think they're well-meaning and very misguided. I think they're going exactly the wrong direction. We may never know who's right,
As a follow-up to that, Pat, and continue more if there's a couple other points, but you did hit something that I wanted to kind of address. When we look at an orthotic and the influence that it may have early on in, let's say, a 4-year-old who hasn't gotten to 70 pounds yet, later in life, do you think, is your hunch anyway, and you're just going out on your hunch and your experience rather than any study, is it your thought that holding that arch that is hypermobile and might have a talus that's dropped in more, is the orthotic preventing the foot from getting worse more, or is it actually helping to allow the muscle development to work in conjunction with the orthotic to maybe create create a better arch in development?
So this is very controversial in pediatric orthopedics. We know that any orthotic requires a certain amount of extra energy because it does change what you might normally be doing. So an AFO on a kid with cerebral palsy might allow them to walk in a more normal gait, but it is going to take some extra energy to walk. And so there's a trade-off. Anytime you put your skeleton's supposed to be on the inside. When we put the skeleton on the outside, there are going to be consequences. May irritate skin, and require fine tuning like that. It is going to take some energy to lug the thing around. Now, there are fantastic orthotics being developed for military personnel to help them carry a heavy pack longer, run faster, even make up for things like having had a leg blown off and still maybe being an active combatant. So orthotic science is in its infancy. It's headed for cybernetics. It's going to be a lot more internal and surgically attached and neurologically activated. I mean, the horizons here are fantastic. Robotics, I guess we could thank the never-ending wars in the Middle East to all the limbs that have been lost, and the fact that urgent trauma is now more manageable through forward positioning and multiple echelon medical care. We can save lives that were lost in previous wars, but they're missing parts, and people have gotten better and better at making up for those missing parts. So that's a really long roundabout answer, and not even an answer to your question. Does a foot orthotic make you grow an arch? Personally, I don't think so. I think it helps keep you from getting worse if it's done right. And now, right is a big question. What constitutes a good foot orthotic? I don't think there's any really concrete data to say one way or another. I almost think it may change through the course of the day. An orthotic that's appropriate in the morning might not be appropriate by evening, particularly in an adult. In a kid, an orthotic that is misshapen can create some disease. Like I always remember one of our professors at Temple talked about, you know, if you've made a supinated orthotic in a patient with hypermobile first ray, you might create enough elevatus to cause hallux rigidus later on. So it's tricky. And I don't know the right answers, but it's
Well, I
something.
know, to follow up your point, that one of Ben O'Nigg's things that he looked at when they were looking at very sort of rudimentary type orthotics is that the arch height that worked best in terms of preventing injury tended to be the one that the patient was most comfortable with. So there was a definite alignment between toleration, comfort, and prevention of injury. Now, that's not to say that that every orthotic or shoe combination should be like you know, a pillow, but when you got to situations where something was held in, and I'm sure you've had this experience in your clinic, where you think that you've got, you know, the child lined up, but it might be one of those hard prefab plates, and the kid just doesn't want to tolerate it, no matter how good the foot looks. So there is definitely kinesthetic input from the patient that has to be obviously taken into consideration. And it at least it bore out in this one study that those were patients that typically did better with prevention of injury.
Was just mentioning this paper where they compared attitudes about treating foot and ankle problems in children with pediatricians, pediatric orthopedists, podiatrists, and general orthopedists. And the two split. And innuendo was that the pediatricians and the pediatric orthopedists, being highly specialized, were right, and that their attitude was nihilistic and don't worry about it, they'll outgrow it. My opinion, again, I was always arguing with Dr. Staley about misinterpreting data, was that really the podiatrists and the general orthopedists who see foot and ankle problems at all ages see that a lot of pediatric problems don't go away. They may morph, they may be a little bit hard to recognize later in life, but when I get peroneal tendonitis and when I fractured my right fibula, that might have been predictable from the day I was born. You looked at my metatarsus adductus foot type, my slightly cavus uncompensated foot type, and you would say, well, of course he's going to twist his ankle and break it. Of course he's going to have tendonitis in his peroneal tendons. It was predictable. So could that have been changed by throwing a splint or a cast on me as an infant? I hope so.
Right.
I'm certainly willing to try. The funniest thing is when parents show up and they say, and pediatricians are my best friends around here. They send me a lot of patients. I brainwashed a lot of them into believing what I believe. But the parents will come in from an unfamiliar pediatrician and I'll say, well, the pediatrician said we're going to outgrow this, or the kid's going to outgrow this, but I'm a little concerned. I say, why? And they'll take off their shoe and say, because I still have it.
Yeah.
I am, I'm the kid's parent. So
well, that's a great teaching point right there. The apple doesn't fall far from the tree, and that's something that I never think about. Actually, well, once in a while, like if they have a really flat foot, but especially in the metaductus situation and we know it historically, but especially if you can actually show them, because they may not be aware of it because it may not be clinically significant for them, but they may have it.
A useful part of that history is see what the parents are experiencing, and often I said, yeah, if you'd asked me what's going to happen to your kid in 30 years, I'd look at your foot.
Well, though, for those that are watching this post-production, I will tell them that you are anything but an over-interventionalist. And this is a perfect lead-in for this colleague of mine that came in to see me. And I'm not saying that there's a right or wrong answer here, but talk to us a little bit because you shared this sort, and unfortunately you didn't get to see the patient firsthand, but through me, I communicated some of the information on the rupture in the Achilles. So
Mm-hmm.
conventional thought had been surgically repair it. And I want you to be very specific in the degree in terms of, even if it's a total rupture, what your findings have been for a non-competitive athlete or somebody that wants to be active lifestyle, and maybe they are a Clydesdale class, not morbidly obese, but maybe just a heavier frame individual who maybe played some, basketball at center or something, and then gained weight appropriately over time. What are the things that you came into sort of communication about at the Foot and Ankle Society meetings that you went to about those types of Achilles severe injuries and the modes of treatment?
Yeah, I believe first do no harm and try to be wherever we can evidence-based provider. Unfortunately, in pediatrics, there's not a lot of evidence, but in the case of Achilles tendon injuries, there's quite a lot of evidence out there. And I was blessed to have the opportunity to work with a clinical consensus panel within the American College of Foot and Ankle Surgeons to come up with a clinical consensus on Achilles tendon injuries. And one of the questions was basically operate or not. Now, the old saw when I was in school was, you got a 5% risk of a re-rupture if you treat it non-invasively. You got a 5% risk of a complication if you treat it invasively. And people have come up with efforts to make the invasive treatment less risky with mixed results. But the overall consensus is that if you have a fresh injury and an otherwise relatively healthy patient, you're going to get just as good outcomes with immobilization as you will with surgery. And so the gut reaction to look at that gap in the Achilles tendon and think you have to sew it back together turns out, based on the meta-analysis of lots of data that exists currently, is that really probably you don't have to do that. Now, there may be some advantages in early intervention in a competitive athlete or a soldier, somebody who has to get back to the field fast, but long-term outcomes are very similar. There's no real advantage after a fairly short time.
And can we also, just for the purpose of this discussion, specify the locations specifically that we're talking about in which areas of the Achilles?
So this is mostly in what's been dubbed the watershed, but one point's going to come out also when this paper is published soon about the fact that there really isn't a decreased circulation there, so it's kind of misnamed. But I'm not going to get into the weeds on that.
Sure.
Except to say that 10 centimeters above the insertion is where it usually ruptures, and it's also where it's entirely capable of healing itself. And another prototypical example of this is in pediatrics. Often in clubfoot surgery, we transect the Achilles tendon. We just poke a little beaver blade in there and cut the thing right in the office with a little bit of local anesthetic. And we don't worry about it reattaching itself because it always does. In fact, the biggest problem is when it reattaches itself too promptly and the equinus component of the deformity comes right back. So, yeah, your Achilles tendon, in fact, all of your tendons have an uncanny ability of being able to find their way back. Anybody who's done a tenotomy on the toe of an older person will say, yeah, it looks great right now. And you come back 2 years later, it's all curled back up again. How'd that happen? Well, the tendon ed needs to be satisfied, is what Dr. Gailey used to say. If you cut a tendon, you better put it where you want it, because it's going to find some place to stick and it's going to try to do what it was originally designed to do.
Well, Pat, this has been fantastic information. I'm so glad that you had the opportunity to be able to share it. And before I shut this, I'll shut the recording down, but I'll say just a couple closing things to you after we shut it down. But it's been great, and I think that people are going to enjoy this recording. So thanks so much again.
Thanks for the opportunity. Howard, you got comments, questions? I don't know. We left you out.
Yeah, chime in there, Howard.
It's nice to meet you, Patrick. Yeah, I guess the thing that's been bothering me is less clinical. So I've been stymied with the future of medicine and how things look on the horizon as as either a small practitioner or as a hospital practitioner, or, where do you see these things going in the future?
It's a
Well,
great question, Howard.
like global climate change, there's a sine wave to it. I think there'll be in the immediate future consolidation of a lot of practices, seeking the economies of scale, and trying to comply with the never ending increase in compliance issues and electronic medical records. And it's just right now it's probably better to consolidate, but I think always there will be the need for individual practices and small practices, and they'll be back within our lifetime. I think it's a natural thing that happens. That happens with stores. All the little stores were eaten up by the giant chains. Look what's coming back right now. All kinds of little stores all over the country. Small mom and pop businesses are popping up like mushrooms. So it's a sine wave that is currently in a particular cycle, but I think it is a cyclical thing.
I mean, one follow-up I have to that question, Howard, that you just kind of put in my brain is how, especially now with COVID, telemedicine, and how patients are gathering information. Some are now more apt to try to do even more research because of fear of coming into an area, right or wrong, where they think there might be some kind of threat of picking up an infection. I'm interested in how, Pat, you think that we have changed in terms of how patients are interacting with doctors. And that's a little different than, just big versus small, but just the actual patient interaction and where that's going with, and what you see in your mind. We all have our own thoughts about, but I'd be interested in yours as well.
So telemedicine's here to stay, and probably is late in arrival. There's certainly a lot of things that we can do, even in foot and ankle medicine, with a virtual meeting. Post-operative care. I have patients that come here from all around the world for us to operate on them, and we were doing some of this a long time ago without compensation, but we were doing it to try and take care of people who don't live anywhere near here. And that's a trend that is going to stay. I hope we can keep it available to podiatrists in the future. And it's something we can develop into a very useful tool. And you combine that with emerging technologies like scanning for orthotics, shipping out devices like you've invented. Just treating people remotely is going to be a fragment of our practice, fairly small one, I think. I wouldn't put it over 5-10% of my whole practice, but I'm doing telemedicine visits every day, and they're very beneficial in a global band.
And certainly part of the continuum, as you mentioned. Well, I think we've just about hit the round hour just before it. So thanks again for doing this, and I look forward maybe in 9 months or a year doing it again, and we can kind of expand on some of the things, and then maybe you'll have some more research.
Sounds good. Yeah, we're working on some things.